Welcome back to The Explainer. Today, we're diving right into part 9 of our series, and we are tackling something absolutely crucial, establishing the exact defensible boundaries between moderate and high complexity conditions. This is a massive distinction to get right, and mastering it is exactly what you need to protect your charts from clawbacks in a rigorous audit. Here's the clinical escalation scale we're covering today. First, moderate versus high complexity. Second, moderate chronic exacerbations. Third, high complexity, severe exacerbations. Fourth, life-threatening presentations. And finally, number 5, defending those high complexity audits. Let's kick things off with Section 1, moderate versus high complexity, the ultimate gray area. We're starting right at what is arguably the most dangerous intersection in medical coding, that razor-thin line separating moderate and high complexity on the medical decision-making table. When you compare the clinical language between these two, there is a massive shift. For moderate complexity, a patient's condition is acutely worsening, maybe requiring a medication adjustment. But high complexity, that actively triggers the consideration of hospital-level care and carries a significant risk of morbidity. You literally cannot just guess between the two. The provider's documentation has to reflect this exact shift in severity. Moving right along to Section 2, moderate chronic exacerbations. So let's step up to our first escalation rung. The crucial point to understand here is right at the end of the clinical definition. A moderate chronic exacerbation means the condition is undeniably worsening, and the provider has to intervene with treatment modifications. But, and this is the absolute anchor, the patient is not at risk of needing a hospital bed. The provider is managing this escalation entirely safely in the outpatient setting. Let's picture a couple of clinical scenarios for a second. Scenario A is a patient with an intermittent asthma exacerbation who needs an albuterol nebulizer treatment right there in the clinic. Scenario B is a patient whose essential hypertension is simply documented as not at goal, which prompts the provider to bump their lisinopril from 10 up to 20 milligrams. Both of these situations fit perfectly into that moderate, non-hospitalized bucket. The patient definitely needs a tweak in their care plan, but they're completely safe to go home. And it doesn't always have to be some dramatic, sudden flare-up either. Even something as simple as a patient not following their diet for hyperlipidemia, resulting in their lab numbers being not at goal, lands squarely in this moderate category. The problem is progressing because of non-adherence, so it requires the provider to step in and address it. But again, hospital-level care, totally off the table here. All right, let's cross the boundary into Section 3, high complexity and severe exacerbations. This is where the clinical decision-making shifts completely. We are no longer just dealing with a routine medication adjustment. The word severe is the ultimate gatekeeper to this category. It has to be explicitly tied to a significant risk of morbidity, and crucially, the active consideration or actual requirement of hospitalization. Honestly, if the provider isn't actively thinking about a hospital bed, you are probably not looking at a high-complexity, severe exacerbation. Just think about the stark clinical contrast here. A moderate exacerbation is a diabetic patient who just needs a minor, routine adjustment to their insulin units. But the high-complexity severe exacerbation, that is a type 2 diabetic experiencing severe, violent swings of hypoglycemia and hyperglycemia. That kind of fluctuation immediately elevates the risk profile to a level where the provider has to stop and consider if this patient is even safe to leave the clinic. And hey, we definitely can't forget about urgent treatment side effects. Take a patient with stable schizophrenia who's currently on clozapine, but they present with urgent new-onset neutropenia found on their monitoring labs. Even though the underlying schizophrenia itself is perfectly stable, this severe, urgent side effect warrants a high complexity level. Why? Because of the massive morbidity risk that neutropenia carries. Which brings us to Section 4, life-threatening presentations. This is maximum severity. This category is absolutely reserved for your most critical charts. We're talking about the red zone here. These are conditions where, without immediate and aggressive medical intervention, the patient could literally lose their life or permanently lose the function of an entire organ system. The probability of severe harm without immediate action is just incredibly high. Classic, undeniable high-complexity presentations include things like acute myocardial infarctions, pulmonary embolisms, severe respiratory distress, acute renal failure, and abrupt neurological changes. But I want you to notice that second category. This maximum severity tier isn't strictly for physical medical threats. It explicitly includes severe psychiatric emergencies where there is a very real threat to the patient or to others. Take, for example, an adolescent patient presenting with a relapse of chronic depression, superficial wrist cuts with actual suicidal intent, and the provider actively considering psychiatric hospitalization. The active suicidal intent, combined with that consideration of admission, firmly anchors this behavioral health presentation in the maximum high complexity tier. It is a direct, immediate threat to life. So, let's talk about Section 5, defending high complexity audits. Now that we've climbed the scale all the way to the top, how do we actually armor these charts against an auditor? Well, this is arguably the single most critical takeaway from today's explainer. As coders and auditors, we cannot assume risk on behalf of the provider. The provider has to explicitly document the what and the why. Why would the patient die? What exact bodily function would they lose? If those specific details aren't crystal clear in black and white, your high complexity level simply will not be supported in an audit. To keep your coding safe, we've got a quick 3-point defensive checklist for you. Before you ever finalize a high-complexity E&M level, run it through these 3 questions. 1. Is the condition actually being managed, or is it just an unmanaged comorbidity listed somewhere on the chart? 2. Is the explicit morbidity or mortality risk actually documented? And 3, was hospital-level care actively considered, even if the patient ultimately refused or ended up being managed aggressively outpatient? If you can confidently check these 3 boxes, your chart is highly defensible. Well, that actually wraps up our deep dive into exacerbations and severity for today. But you definitely don't want to miss out on the grand finale of this series, Part 10. We're going to take all of this theory we've discussed and put it into practical, actionable chart audits using clinical case studies and the Master Review Checklist. It's going to be a great one. Decode Healthcare with Harshal. As you look at the charts crossing your desk today, ask yourself, based on what you just learned, are your high-complexity charts truly audit-proof?